Hello and welcome, everyone. My name is Matt Shepard, and I'll be your moderator for today's webinar on Medicare Skilled Nursing Facility Residents' Rights and Staffing. Our presenters today are Center for Medicare Advocacy Senior Policy Attorney Toby Edelman, Richard Mollot of the Long-Term Care Community Coalition, and Connecticut State Long-Term Care Ombudsman Mairead Painter. The Long-Term Care Ombudsman Program, as you can see if I actually move the slides, advocates for residents of nursing homes, assisted living facilities, board and care homes, and similar adult care homes. They provide information about how to find a facility and what to do to get quality care, and they're trained to resolve problems. The Long-Term Care Community Coalition is a nonprofit, nonpartisan organization dedicated to improving care and quality of life for the elderly and adult disabled in long-term care. They're actually home to 2 local long-term care ombudsman programs in New York, and they provide in-depth policy analysis and advocacy, data on nursing home staffing, quality and oversight, and education for consumers, journalists, and policymakers regarding those who live in nursing homes and assisted living. And of course, the Center for Medicare Advocacy, as many of you probably know already, is a national nonprofit law organization that works to advance access to comprehensive Medicare coverage and quality health care for older people and people with disabilities. The center focuses on the needs of people with longer-term and chronic conditions, and their work includes legal assistance, advocacy, education analysis, policy initiatives, and litigation of import to Medicare beneficiaries nationwide, all of which is based on the experiences of the real people who contact us every day. Before we get rolling in earnest, please bear with me for a little housekeeping. If you can hear me, you've used the information in the email you received after registering to successfully log into the webinar, and you've either dialed in by phone or have good quality working speakers on your computer, either of which will work great for you. Our audio quality will be at the whim of your hardware and your internet connection if you're using that computer audio. So do please be aware that if you have issues, you can always go old school and dial in by phone to the phone number that was provided on your confirmation email. That number also appears in the audio tab on the control panel that you should see at the right of your screen. We do have several presenters. We're going to be pulling presenters up here and there, so bear with us as we make those switches and cameras come on and off. A couple more things about that control panel I just mentioned. I am sure that a lot of you are familiar with this setup or similar, given that this is sort of how things are done nowadays, but there are a couple key features that we use. Please note the buttons at the tab at the left of the panel. There's a little orange arrow to let you hide the panel so it's not in your way. There's a little square that'll let you watch the presentation in full screen view. And finally, there's a little picture of a hand. That's the best feature of the control panel. That's going to be used to indicate that you have a question or comment, because for the bulk of the presentation, we're going to keep attendees muted since there are so many of us. But when we open it up for questions, time permitting, you can use that icon to indicate that you have something to say, and I can unmute you. Don't worry if we don't get to questions live or you're too shy to ask it out loud. We do have a questions panel on that control panel, and you can type your inquiry right into that, and I can relay it to our presenters. If we do take a live question, please do try to be brief so that we can get to as many folks as possible. I know the tendency is I am recognized, I'm going to go and take my moment, but we do have a lot of other people on here. So thank you all once again for attending today. And now I'm going to hand things over to the center's own Toby Edelman to get us started. Toby.
Thank you, Matt. I just want to add some appreciation to Mairead and Richard and thank them for joining the Center for Medicare Advocacy on this webinar today. They are 2 of the most effective advocates for nursing home residents in the entire country and have become wonderful colleagues and friends. So thank you so much to them. We have 2 themes today that we want to talk about in this webinar. First, what the public health emergency meant and still means for residents, and then President Biden's nursing home reform agenda. Next slide, please. A public health emergency was declared in March 2020 due to the COVID-19 pandemic. As a result of the declaration of the public health emergency, the federal government was authorized to waive federal law and regulations that protect residents. It gave blanket waivers, which meant nursing homes didn't have to ask for the waiver, automatic across the country, and it gave many waivers. So here are just a few. For residents, we know they were not allowed to have visitors. They didn't have congregate dining. They couldn't have activities that in a larger room with other residents. Essentially, residents were kept to their rooms. Pretty horrible situation for them. An important waiver that continues, and I'll talk about that in a moment, an important waiver was the requirement that is in the federal law and regulations that people not be used as aides for more than 4 months unless they are trained as required by the state, meet the state training requirements, which is minimum of 75 hours. So that was a big change in who would be allowed to provide care to residents. Another big change was the suspension of standard surveys. What state survey agencies did was conduct infection control surveys. They were focused explicitly and pretty much solely on infection control, except for a few limited situations where they considered the problem's immediate jeopardy to residents. Next slide, please. As the public health emergency continued, CMS lifted various waivers of the law and regulations for nursing homes. One by one, as they went along, they tried to lift them as quickly as they could. CMS modified visitor restrictions, recognizing essential caregivers at some point, and it advised states that it would be good if they would try to start doing standard surveys. Next slide, please. The public health emergency officially ended May 11th, and when it ended, all remaining waivers were lifted. But there's one exception, or at least one significant exception that I've been very concerned about, and that's the nurse aid training requirement. As I said, facilities were allowed, or the states were allowed to accept less than the 75 hours or whatever they required as a training requirement. And during the pandemic, CMS said that states could allow these temporary nurse aides, many of whom had only taken the American Healthcare Association, the Nursing Home Trade Association's 7-hour online training program. So the CMS said states could allow these people with 7 hours of online training to sit for the CNA test without first getting the state mandated training. American Healthcare Association claims that 300,000 people took their training for temporary nurse aides and that many of them are working in nursing homes. So what I'm concerned about is a continuing permanent change in the nursing home workforce. We have many more people who have not actually been fully and comprehensively trained. Next slide, please. So now what we want to do is talk about where we are now with the official end of the public health emergency. And I'm going to turn this over to Mairead. Thank you.
Thank you so much. I'm honored to be presenting here today with Richard and Toby and to be speaking regarding this topic. And we are happy to be able to say that we are at the end of the public health emergency and coming out on the other side of it. Next slide, please. So where are we now? What are we facing? And what is the experience that we're hearing from residents and from family members and friends related to the experience of residents? Across the board, we're hearing about staffing challenges. One of the things that we're hearing, at least here in Connecticut, is about facilities admitting residents, in some cases, even when they know that they don't have the staff to currently care for their residents already there. We've also had complaints from staff about this, where they will have very large assignments, sometimes be over what the state requirements are for staffing, and then still residents will be admitted from the hospital on top of the residents they already have to care for, further causing delays in care. And we know that when someone is newly admitted, they have even greater need and demands on staff, needing to adjust, learning what their care needs are, and that impacts residents. Residents report not receiving care due to low staffing levels in general. We were hearing about an increased number of falls and other incidents due to lack of supervision. We've had an increased reporting of wounds. We hadn't really had many reports of wounds. We weren't receiving calls about wounds and people waiting long periods of time prior to the pandemic. Next slide, please. Facility licensing surveys have resumed, and here in Connecticut, we've seen that pace pick up. We're seeing very robust surveys here, and we're seeing a high numbers of immediate jeopardy calls. And with immediate jeopardy, we're seeing incidents where it's a lack of supervision, care concerns. At times, there are things that the facility is reporting, and at times that they haven't reported. And in general, surveys are having a high number of findings. I know in some cases, people feel that that's because there's been a gap in time related to the amount of surveys and when the last time a survey was done. However, we are seeing that what they're finding are things that are consistently happening, and that because of the management and oversight in the facilities is why we're seeing some of these findings and accidents, and not having the support for the staff. The outcome for the residents is where we're seeing that jeopardy. Excess beds in the system overall, and question about appropriate residents and what that looks like. So here in Connecticut, we have an excess number of skilled nursing facility beds, and really working to ensure that the appropriate residents are receiving care and services in skilled nursing facilities. And that does mean individuals who may have a substance use disorder or maybe a mental health condition, but ensuring that they have the appropriate supports within the facility and the opportunity to least restrictive environment and the opportunity to regain that community residence if they wish to do that. And once they no longer meet the nursing home level of care, that there's a plan for them to discharge back to the community or to the setting where they would like to choose to receive their long-term services and supports. Next slide, please. So this speaks to the lack of appropriate discharge planning. When we're going into the skilled nursing facilities, we are not seeing discharge planning and person-centered plans that happen at the time of admission. People should be meeting with residents and family members from the time they're admitted and talking about their discharge plan. What do they want to do? What are their individualized goals? We see a lack of unbiased information related to choice for residents. A lot of information regarding spending down, giving private pay funds to the nursing home, doing that spend down while in the nursing home, and then applying for either money follows the person or waivers or other services to regain community residence or moving back to the community, where that's a real challenge. We want to see that individuals have choice and are fully informed on the front end, that they don't necessarily have to sell their home or get rid of a vehicle, that they can return to that house and be supported in that community setting, or maybe have a waiver service. Maybe it does mean selling that house, but having that done by a third party or someone not related to the facility, so that we can ensure that they're fully informed and that they have choice in that. That's also not to say that choosing to stay in the facility is a bad choice. For some individuals, it's the most appropriate choice, and it's the choice that they want to make, and ensuring that that's not biased either. Access to least restrictive environment. We want to ensure that people have choice to community housing options. We know that that's something that's been a barrier here in Connecticut because of the rental community, and that's been impacted by the pandemic. We've also have something here called residential care homes. And since St. Patrick's Day, trying to encourage them to meet the home and community-based settings rule and all of those standards, so that individuals can receive access to waiver services. And what I'm talking about, the home and community-based settings rule, ensuring that people have meaningful participation in the community, that they are in the residential care home by choice, that people who live in the residential care home make up a broad sense of who is in community, access to the greater community, services, and that it feels like a home-like setting, access to food, locking doors, control over their living environment. And we haven't really seen that across the board. And that's something we're really encouraging and hoping to see here, so that we can support people in that level of care. Next slide, please. And now I'll hand it back to Toby.
Thank you, Mairead. What we want to do now is talk about what we can look forward to, the president's nursing home reform agenda. And Richard and I are going to split this discussion. Next slide, please. In February 2022, in the State of the Union address, President Biden announced a need for nursing home reform, and the White House released a very comprehensive fact sheet. The president reiterated the need for reform in his 2023 State of the Union address, and there are links to all of these materials. Next slide, please. The White House made the case for why we need a new reform agenda now. And this is an important sentence in the document. The pandemic has highlighted the tragic impact of substandard conditions at nursing facilities, which are home to many of our most at-risk community members. The administration pointed out that more than 200,000 residents died from COVID, nearly a quarter of all COVID deaths in the United States, nursing home residents. But nursing home residents make up 0.004% of the more than 300 million people in the country. So this is where deaths were concentrated. It made people realize something is going on in nursing homes. It's a serious problem. Next slide, please. And the White House fact sheet also had this pretty strong statement. Despite tens of billions of dollars of federal taxpayer dollars, too many facilities continue to provide poor, substandard care that leads to avoidable resident harm. In fact, failure to comply with federal guidelines at nursing homes is widespread. That's the reason we need a reform agenda now. Next slide, please. The agenda that was announced in 2022 is very comprehensive. It discusses all kinds of things. But what we want to focus on today is three of them. First, a minimum nurse staffing requirement, a ratio. Then ownership and finances, transparency and accountability. And finally, strengthening enforcement, just part of what the agenda calls for. Next slide, please. There really is no dispute that decades of research consistently show that higher staffing levels lead to better resident outcomes, fewer deficiencies, fewer deaths. There is no study that I'm aware of that says that residents do better when they have fewer nurses providing care to them. Next slide, please. In 2022, the administration did a request for information about staffing. It was starting to deal with this issue, asked for people to send in comments. Charlene Harrington, who is the lead researcher on nurse staffing levels in the country, and Elizabeth Halifax at the University of California, San Francisco, on their own behalf and on behalf of 79 additional geriatric nursing experts, compiled a list of studies. 110 studies from 1977 to 2022 showing the same thing. Better staffing means better care. So there's a link to their comment letter. If you want to have any information about any of these 110 studies, you can find it right there in their really excellent comment letter. We had the same findings during the pandemic about staffing. There was a study of Connecticut nursing homes that has been widely discussed that said if there were 20 additional minutes of registered nurse care per resident per day in these Connecticut facilities, that additional 20 minutes per day per resident was correlated with 22% fewer cases of COVID among residents and 26% fewer deaths of residents. Just 20 minutes a day made an enormous difference. New York State Attorney General Letitia James wrote a report looking at the pandemic and what was going on in New York nursing homes, and she said she found that the highest death rates in facilities occurred in facilities with 1 or 2 stars in staffing on a 5-point scale. 1 or 2 means much below average in staffing or below average, not enough staffing. So staffing is obviously the most important predictor of good care. Next slide, please. We need to strengthen the federal staffing standards because the current requirements are totally insufficient to ensure that residents get the care they need and that the nursing home reform law promises. The 1987 law and the regulations require 8 consecutive hours per day of a registered nurse, 24 hours per day of licensed nursing, and otherwise sufficient staff to meet residents' needs. Next slide, please. The law also, because we didn't get a staffing ratio in the 87 law as many advocates were trying to get, The nursing home reform law required the federal government to conduct a study, and they had Apt Associates as the contractor to do a study. It took several years. Apt issued a 4-volume report, and it issued it in 2001. It looked at staffing levels in 2 ways. What is the level below which residents suffer avoidable harm? And secondly, how much staff time is needed to meet some of the requirements of the 1987 reform law? What Apt concluded after this multi-year, multi-volume study is that was 4.1 hours per resident per day, consisting of 3/4 of an hour of time by a registered nurse, 0.55 hours per resident day for an LPN or LVN, and 2.8 hours per resident day of CNA, certified nurse assistant time. Next slide, please. Facilities did not meet that standard in 2001. 95% of facilities could not meet that standard then, and most facilities today also do not meet that standard, even though we know that resident acuity has increased and that resident care needs have increased. Residents are more dependent, they have more physical and mental health needs, more likely to have dementia, more frail, they need more care. Facilities still can't meet those needs. Kaiser, or KFF, usually formerly known as Kaiser Family Foundation, found that only it should be 23% of facilities met the 4.0 standard in 2023. 23% met the standard. But they also found that there were facilities, the 23% of facilities were living in facilities that meet the 4.0 standard or higher. So 23% already meet that standard, and residents in 5 extremely diverse states, including Oregon, North Dakota, and Maine, already meet that standard. So it can be done some places, it is being done some places, and we don't want to go backwards. Next slide, please. So what does the Biden-Harris administration say in its white paper and in its conversations about nurse staffing? They say we need reform to ensure every nursing home provides a sufficient number of staff who are adequately trained to provide high quality care. Seems like something we all could obviously agree with. Next slide, please. So what CMS is doing is for the first time talking about nurse staffing ratios, actual numbers, because the loosey-goosey federal standard we have now is insufficient to get enough staff, as all these studies have shown for decades. In 2022, CMS issued a request for information. It reviewed past research, and it has conducted a new study, also by Apt, and hosted calls. It's done a lot of things to try to get information from people about what staffing should be, what the problems are, why staffing matters. There are proposed rules now, and there is this draft report the report is probably final. The rules are in draft form for staffing ratios, and these are at the Office of Management and Budget. We're expecting them to be published soon for notice and comment rulemaking, but we've been told even today that changes may be made from the current draft. So we just don't know yet exactly what these rules will say. But the administration has gone forward on trying to meet this promise of getting staffing standards for residents. Next slide, please. The second issue that I want to talk about is the ownership and finances, transparency and accountability. The administration said that research has found resident outcomes are much worse at private equity-owned nursing homes. And that is absolutely true. There's plenty of evidence. Ways and Means Committee held a hearing in 2021 about private equity in healthcare in general. And one of the researchers testified about nursing homes that were owned by private equity. The researchers had done a study of private equity ownership takeover of nursing homes between 2000 and 2017. What they found was that staffing levels went up, use of staffing levels went down, use of antipsychotic drugs went up, and Medicare spending went up. But the most shocking thing they said was that they found that 20,150 additional Medicare beneficiaries died because of the poor care in the private equity-owned facilities. That was a shocking number. It was shocking to them, it was shocking to everybody who heard it. So the Biden administration is on very solid ground in saying we have to do better about private equity owned facilities and other privately owned nursing homes. The administration also called for increased accountability for chain owners of substandard facilities. It said we need a database of owners and operators, and we need to improve transparency of ownership and finances. Next slide, please. So the administration has implemented some of these proposals now. In February, it published proposed rules to implement the provision in the Affordable Care Act about transparency of ownership information. I know many of us submitted comments on these and suggested a number of stronger points that could be made, but the comment period has ended, but the administration did try. There is a very strong letter, a bipartisan letter by senators and the House. So it's bipartisan and bicameral, including Senator Grassley, which is interesting. He has not been on these letters with Democrats supporting stronger standards. This is important to him, and it's important to all of them. And this group recommended strengthening the proposed rule even further. There's also strong support letter from Medicaid fraud control units. So there is a lot of support for this recommendation. The administration has also made good on its promise to provide more information on facilities that are commonly owned. Last month, CMS started providing a link on the Care Compare website to a separate federal website, the data.cms.gov, where we can see how affiliated facilities perform. So the website includes information about facilities that are under common ownership, and it includes the information from all the facilities that it's aware of that's on Nurse and Compare for them individually. There are 20 facilities. It takes the 20 facilities and says, this is what we know about them. It tells their star ratings in each of the areas, survey, staffing, quality measure, and the overall rating. It gives staffing levels, says how many registered nurses they've got, talks about deficiencies and penalties and more. And CMS says it believes that by providing this information, facilities will be inspired to do better and families will have more information that will be useful to them. My reaction is something else we get out of this is recognition that we need some corporate-wide enforcement, that it's frequently corporate leadership that are making decisions that sort of trickle down to the local facilities who are forced to deal with the reimbursement that the corporation gives them or the leadership gives them. Tells us that problems in one facility are common to facilities that are commonly owned. But that is a second area where the administration is trying to implement the proposals that it announced in 2022 and again in 2023. Next slide, please. And the last thing I just wanted to mention was enforcing the standards of care, which is one of the weakest parts of the law. As we know, most deficiencies are usually called no harm, 95% are called no harm or substantial compliance, and most of the enforcement is limited to deficiencies that are classified as harm or jeopardy. And we actually, the Center for Medicare Advocacy, along with Long-Term Care Community Coalition, put out a publication about no harm deficiencies saying, really, do you think this is no harm? Bad things happen to people and they're called no harm. And we do that, and you could certainly get that on our respective websites. So one of the things the Biden administration called for was adequate funding of inspection activities. And again, we have very strong support from this in a Senate Special Committee on Aging hearing and staff report in May, just this past May, about how seriously state survey agencies are understaffed, much worse than last time the Senate Special Aging Committee on Aging looked at this in 1986, even before the reform law was passed. It is much worse now. And yesterday, I believe Long-Term Care Community Coalition had a webinar, which will be available on their website, featuring the lead author of that report, Peter Gartrell, talking about what they found and what it meant, the significance for residents. So there's strong support for a need for staffing. Survey agencies need to improve their ability to go out and find problems. Newsweek also did a nationwide investigation, had a very strong article about how there are not standard surveys. 1,500 facilities haven't been surveyed for years. If you look at Care Compare, you can see in many instances the facilities have not been surveyed for 2.5 years, not a standard survey. That's a very serious concern. The administration also promised to improve the scrutiny for the poorest performing facilities and to expand penalties and other sanctions. Next slide, please. So there's been implementation of these recommendations as well. Certainly the president's budget proposed a $97 million increase in funding for survey and certification activities. That, of course, didn't go through just as written, but we are hoping that there will be an increase in survey and certification budget when that finally happens, when we get a bill through. The administration also in October put out a guidance document about special focus facilities, trying to improve and strengthen that program, the 66 facilities in the country that are considered among the worst performing facilities. We would also like to see more effort on the candidates, the 400 candidates in the country that meet the criteria for special focus. They have a lot of deficiencies, a lot of very serious deficiencies over a very long period of time. That's the definition of a special focus facility. 400 more that are the same, but nothing is really done with them. So we could hope for some more work on that. As for expanding penalties and other sanctions, we haven't seen anything on that part of the reform agenda yet. Next slide, please. I think what we want to do now is turn to Richard, because staffing is what most of us are spending all of our time on right now. The nursing home industry is out like crazy, opposing increases in the staffing ratios and making many arguments that are quite bizarre. And Richard will talk about the kinds of arguments we are trying to make in opposition and in response to the industry's claims. So Richard, please take over. Thank you.
Thanks, Toby. I just wanted to say a quick thanks to the Center for inviting me to speak today, and just note how what a privilege it is to be speaking both with Mairead and with Toby today. I also, just before I got started, I just wanted to quickly chime in on some of the things that Toby said at the start regarding the CNA training issue. As you might recall, she had said that during the early start of the COVID pandemic, CMS relaxed the standards on training that have been in place for several decades now for certified nurse aides, and that many people were working as CNAs in nursing homes with as little as 7 or 8 hours of training. So I just wanted to note for people, because as she said, a lot of those people now have been essentially grandfathered in and allowed to take the CNA test and be working as CNAs. I think it's really important for everyone to remember something I think about is that CMS said that it was not decreasing any standard, any right of resident to receive appropriate care and services. They were only relaxing the training. Of course, does that really make sense? That's another question. But they did not they did not remove or weaken the right of every resident to receive the care and the services that they need to attain and maintain their highest practicable well-being, both clinical and, of course, living with dignity, et cetera. The other issue I wanted to raise is because we have these people now who have had such little formal training that training is really important. CNAs learn about infection control, which is of course very important, especially when we think about COVID, but they learn about helping residents to eat. And dining is actually a very, eating and chewing and swallowing is a very complex task. They learn about dementia care. They learn about cultural competence, et cetera. So those things are really important. So just very quickly, we always have had and continue to have the right to receive the care and services that we need as residents, but also that we should be concerned and keeping our eyes out for care that is not up, and for workers who may not be equipped to provide the care that they're being charged with for residents. Without further ado, I'll move on. Just talk about some of the things that the nursing home industry is saying and providing some facts against or in light of some of those arguments that they're making. Next slide, please. Thanks. Next slide, please. So this is a quote I thought this was really interesting from the Times. Long-term care continues to be understaffed, poorly regulated, and vulnerable to predation by for-profit conglomerates and private equity firms. And this is from 2020. So this is several years ago. This is why nursing homes failed so badly in the COVID pandemic, because we've had years, I would say even decades clearly, of increasing ownership sophistication, as Toby was talking about, private equity, other sophisticated private entities. And I would say even unfortunately, the nonprofits, a lot of nonprofits have adopted some of these very sophisticated mechanisms for not putting the money that they're paid for care into care. Next slide, please. So just a little bit of a timeline here, as you can see in the blue to green. Originally, in prior to Medicare and Medicaid coming in and paying for nursing home care, most nursing homes were, for lack of a better way of putting it, mom and pop operators. They were people, they were standalone facilities. They weren't attached to a chain. They were operated by people. If they didn't necessarily, I'm not saying they were saints, but they were people who, at a minimum, wanted to keep up having a successful business in their community. And then we saw increasing infiltration by corporations, limited liability companies, limited LLCs, which is a way for people to disconnect any kind of limited liability, any kind of liability for what goes on in the facility to the owners and the operators. About 15 or so years ago, we started to see increasing investment by real estate investment trusts, big money players coming in, and then private equity and private investment. Having this infiltration, the attraction of these companies is really twofold. One is that there's clearly a lot of money in this field. You would not be having sophisticated owners coming in, or sophisticated business owners coming in to buy up nursing homes if they were truly operating on razor-thin margins or losing money. I mean, that just defies common sense. But the other part of this is that these ever more sophisticated mechanisms, they allow the owners to escape both legal and financial accountability when there's resident suffering. And that, again, that kind of feeds into the poor care with impunity that we see far too often. Next slide, please. So this is just a little graphic. The issue is, and as Toby got at, and this is really something that I've spent my career focusing on, is we have very poor enforcement of minimum care standards. We have virtually no accountability for how the money that we pay for nursing home care, how it's actually used. And we have a very marginalized population. We have a lot of ageism, we have a lot of sexism, we have a lot of racism, and that all comes into play in the nursing home environment, where the residents are older, tend to be older, are of course very frail. By definition, they need 24-hour skilled nursing. Most residents and most workers are women, and most workers are both women and people of color. So you have this tremendous marginalization, which I think again has in turn made it an opportunity for predatory operators to come in and to exploit those circumstances with impunity. Next slide, please. So this was a really interesting study that came out by Jordan Rao, who's working for Kaiser Health News, and it was also co-published in the New York Times. And what Jordan found is that 75% of nursing homes in the United States use what are called related party transactions. And that means that they hire and they contract with other companies that they themselves own for services. We see this in a lot of different ways. We see it with food services, with laundry services, with therapy services. even with hospice services. The most, I would say the biggest way in which this mechanism is used is for the rental of the building and the underlying property. And what I've seen over and over again in my career is that someone will come in and will buy either a single nursing home or maybe a nursing home chain, and then almost immediately they'll turn around and they will sell the underlying property to either a third party, but quite often to a third party that they themselves own, and then they can pay essentially themselves rent, and there's no limitation on what they can actually pay. It's supposed to be that any kind of contracts has to be what's appropriate for the community in terms of cost, et cetera. But unfortunately, we keep on talking about enforcement of quality. There's no enforcement of financial integrity either. So these operators can really, as this headline says, how the owner can feed millions of dollars into a corporate web where the money just kind of disappears. It doesn't go into resident care. It goes towards profits that are hidden in related party transactions. Next slide, please. So here, kind of to reiterate, in the absence of meaningful enforcement, nursing home operators can largely provide any level of care and any level of staffing, and any quality of care and quality of life services that they choose. So as I think Toby mentioned before, we have about 25% of facilities in this country that are already providing at least 4.1 hours of direct care staff time, nurses, LPNs, RNs, LPNs, and CNAs on a daily basis. So we know it can be done. We have 15,000 nursing homes in this country. It's not just one or two that are doing it, it's 25% that are doing it. But in the absence of enforcement of minimum standards, it's entirely voluntary. And we're seeing more and more facilities, unfortunately, both for-profit as well as non-profit, that are just having this race to the bottom. Next slide, please. I'm going to give two examples. I'm going to give them pretty quickly. I think everyone has the slides, and we have these materials on our website as well. One example is staffing. Again, as we said a number of times, a study that came out 22 years ago found that residents need at least 4.1 hours of nursing staff time per day in order to meet their basic clinical needs. That's not care with dignity. That's not getting a steak dinner or fancy treatment. It is just to meet basic clinical needs. Unfortunately, the average nursing home provides about 3.62 hours. Nursing home industry will say, oh, we're facing the biggest challenges ever. That's actually a very consistent number. We've been tracking that information for many years, and it's been pretty consistent. What I want to note here is that even though short staffing is a long-standing and pervasive problem, it's almost never cited by the state survey agencies. As a result of the lack of citation, of course, there's no penalty. There's only a penalty very rarely when there is a citation. If there's no citation, of course, there's not going to be any penalty at all. So what that tells the industry, in the absence of a numerical, meaningful, good standard of care, which we hope that the Biden administration will come out with, in the absence of that, facilities can provide any level of staffing they want with impunity. So they get paid and there's no penalty. Next slide, please. I'm not going to spend a lot of time on this. As you can see, we did a study 2 years ago, and we looked at state oversight. And this was really interesting to me. This is pressure ulcers, which are a terrible problem. Pressure ulcers are almost always preventable and treatable with appropriate care. According to the CDC, they're one of the most important measures of the quality of clinical care in a nursing home. What we found is that even though it's prevalent in nursing homes, 7.25% of US nursing home residents have an unhealed pressure ulcer, and that's likely a significant undercount, that facilities are almost never, ever cited for poor pressure ulcer care. And this was one of the most remarkable things to me, is that the second to last box from the bottom is that even when a state does cite a facility for inadequate pressure ulcer care, so there is a pressure ulcer, which is by definition a wound. They have a wound, and they've actually been able to substantiate, the state agency, that the wound was the result of inadequate care. They still only identify that as harmed about 23% of the time nationwide. How is that possible that a wound that results from neglect is not identified as harm? Next slide, please. So I want to address the two big myths that the nursing home industry is now perpetrating with our members of Congress, our state legislators and governors, and with the Biden administration too, pushing the Biden administration to weaken any proposed rule or do away with any proposed staffing rule. The first myth is that nursing homes are underpaid. Next slide, please. So the truth is, as I noted before, most nursing homes in this country are run for profit, and they're seen as attractive investments by investors, by very sophisticated investors. We've seen more and more private equity, real estate investment trusts coming in and investing in the sector. And there's virtually no limitations, to how they take the money that's supposed to be going in for resident care. Most of that money is taxpayer funds through Medicare and Medicaid programs, and divert that into profits. Next slide, please. So a little bit, the provider industry often talks specifically about Medicaid funding. And they say, oh, Medicaid, we're losing money, we're losing $10 a day, we're losing $20 a day per resident on Medicaid. There is no independent verified data anywhere showing that that's accurate. And even the federal, it's called MACPAC, the agency that advises Congress and is nonpartisan, has said that there is not enough validated information to accurately determine whether or not what the industry is saying is true. What we see here, and we have this policy brief on our website, is that the revenues from Medicaid have gone up steadily. The nursing home industry keeps on saying, oh, we don't get enough money, money hasn't changed in years. That's just not true. And as Toby's research has found, and I'm sure that's on the Center for Medicare Advocacy's website, they received, I think it was 45 states, according to Toby's research, indicated that the nursing home industry received money from the states, 45 states, as a result of COVID. So they got big bonuses, and we've seen profits actually go up during the COVID pandemic. Next slide, please. Now, Medicare funding. Now, even with the related party transactions that many facilities are using to hide profits, even with bloated administrative costs, et cetera, even with all that, what the industry, with the nursing home self-report showed that for 20 years now, they have had double-digit Medicare profits. But as I note here, just in the, and this is from the MedPAC, there was MACPAC I mentioned before, there's the MedPAC, Medicare Payment Advisory Commission, also nonpartisan, that advises Congress. They said, unfortunately, the focus of Medicare rate setting has been almost entirely on controlling costs rather than ensuring quality. Medicare prospective payments are based on estimated costs and not on actual expenditures. That system allows nursing homes to keep staffing and operating expenses low in order to maximize their profits. Because if they don't spend it appropriately, they don't have to give it back. If they spend it for something that is disallowed, they don't have to give it back. It's just, you try to think about what other system would that be allowed. It's hard to imagine, yet when we allow an industry, when we allow operators to care for our most vulnerable citizens, we allow them this wide, lot of leeway, in which to use the money or even not use the money on resident care. Next slide, please. I just want to quickly mention, there's actually, this is one of the most profound studies I've read in my life, is from the Office of the Inspector General for the Department of Health and Human Services. And what they found is even with these, with Medicare residents, in which again, double-digit profits for 20 years, based upon the nursing home's own reported information, they're still making double-digit profits. OIG found that within about 2 weeks of entering a facility, almost 60%, two-thirds of residents were harmed. One-third of residents were harmed, I'm so sorry. And about 60% of those harm was preventable, and attributable to poor care. I mean, imagine that 1/3 of the residents who are coming in for whom you're making big profits, even those residents are not being provided safety. Again, 60% of that harm was preventable and attributable to poor care. Next slide, please. I'm going to go quickly because I want to leave time for Q&A. Myth number 2, it's impossible to find enough nursing staff. This is something, next slide, please, that the industry has been saying for decades. I started about a little over 20 years ago, but I read reports from the 80s in which the industry is saying the exact same thing that I just heard them say today on a briefing that they did for Congress, saying that, oh, you know, they want to hire more staff, but they can't because they just can't find the staff to do it. And the issue is not one of finding staff. The issue is one of retaining staff. And I just noted 2 studies here that showed, and this continues up to this day, that nursing homes have on average a 50% or more turnover rate. So of course you're not able to have enough staff. You have this constant turnover. Why do you have constant turnover? Poor payment, poor salaries, very dangerous working conditions. It's always one of the top most dangerous working conditions to work in a nursing home, according to the Census Bureau. And the working conditions are often horrific. Staff are always in triage mode. And, you know, too often we hear about residents, I think Mairead mentioned it, that are caring for, staff that are caring for too many residents, 15, 20, sometimes even 40 residents. Nobody can do that. People get burned out and they leave, and that's really where the problem is. Next slide, please. So the other thing, just very quickly to reiterate, the industry again claims they can't find enough staff and they don't get enough money to hire enough staff. And again, both of these claims are dishonest, and we are saying that based upon the facility's own self-reported information about turnover, about where the money's going, et cetera. This is not something that we're making up. This is something that we're getting directly from the nursing homes themselves. The high turnover rates, they're just chewing up and spitting out individual workers. And that in the absence of oversight, they are pulling money away from resident care. And fundamentally, as I note here on the bottom, it doesn't matter. It really doesn't matter. It doesn't matter what their claims are and whether they're true, because nursing homes are not a warehouse. It's not a gerbil farm where you're just putting in, as you know, you're storing as many things as you can, as much as you have room for, pulling in as many people as you have beds to put them in. When you don't have enough staff, we have to demand and expect that they are going to have enough staff to meet their residents' needs. Next slide, please. So I'm just going to take a minute. Our website is nursinghomes411.org. Next slide, please. Next slide, please. So we have information on every state, nursing homes in every state, on staffing, on antipsychotic drugging rates, on enforcement actions, and more. Next slide, please. This is just how you can see where the nursing home staffing data is. We actually just reported the fourth quarter data for 2022 in searchable files on our website. This was just in the past couple of days. Next slide, please. And I just want to mention a couple of our resource centers. One is we have a whole series of forums and tools for residents, for families, for ombudsmen and those working with them on resident and family council development, forms and tools for tracking for any issues you might be facing with the facility, et cetera. Next slide, please. Our Dementia Care Advocacy Toolkit. Next slide, please. And this is part of the Dementia Care Advocacy Toolkit, is we have a lot of fact sheets on residents' rights that you can use and people can use to support their advocacy for individual residents or their systemic advocacy. Next slide, please. So just wanted to say and reiterate in conclusion that federal data, numerous studies, and the nursing home's own self-reported data and information say that they're increasingly run by for-profit entities, They have become increasingly sophisticated in obscuring information about their ownership, money that goes out in related parties, and where the money they receive from us goes. The oversight mechanisms, enforcement is weak. We're really hoping that the Biden administration will address that issues, and that the industry's arguments in defense of perpetuating these longstanding problems, especially insufficient staffing, are unsubstantiated and, again, irrelevant. It is not a warehouse. Thanks so much. I'm going to end with that. Thank you.
All right, thanks very much, Richard. If you'll stay on, yep, we'll call up Mairead and Toby.
Yeah.
We only have a few minutes here, but we definitely have some questions and some hands up. I'm going to go with one of our written questions first. Thanks for your patience, everybody, with your hand up. Adrian asked, ages ago, I think even before you mentioned them, Toby and Richard, as private equity firms are buying out these long-term care facilities, how can this Biden agenda or similar be achieved when it is so contrary to a for-profit model? And how can enforcement be achieved when these companies are hiding behind so many layers?
Well, we
Toby?
do have the model of the New York Attorney General, who is filing lawsuits against nursing homes and identifying through Medicaid forms who the owners are, who the secret owners are, individuals, the children, the children-in-law. She has really, when you read one of these petitions from the New York Attorney General, the list of defendants is phenomenal. They just figure all out, the various companies that are the related parties. So it can be done. And I know that other states are watching what the New York Attorney General is doing. She's doing an incredible job. So, it's piercing the corporate veil. I guess that's the legal theory. And she's trying to do that. Get the money back and get some of those people out of the business permanently. That would be really wonderful.
I would just quickly add that, we've been urging, and that includes Toby, of course, we've been urging CMS to look at, identify these owners and then go after them. And I'm not saying go in and arrest everybody in all the facilities. What I'm saying is that if you knew that that the owner of, say, the Attorney General went into the Centers Healthcare, which is operating in 4 states and 4 facilities. But if you see that, it's very easy. The data we just talked about, ownership, et cetera, you can find out the other centers owners and at least look and see, are they staffing appropriately? Do they have outrageously high antipsychotic drugging rates or falls rates, et cetera, and investigate. Use that as a stepping stone to investigate what's going on and to hold them accountable.
And Toby,
go ahead.
Toby, I'd like to add that here in Connecticut, our Attorney General is trying to pass a law this year to be able to file some of those lawsuits. So really looking at what are the rules in your state, advocating for laws that hold long-term care facilities accountable and move transparency forward. We're allowing up to $50,000 per related party to be able to be given and not have to be explained. Well, that's taxpayer dollars. Why does anyone get any type of money? And it was decreased to $30,000 this year. Due to a bill that we worked on, but I don't understand why it's any dollars. Why are any public dollars able to be given to a related party and we don't see that level of accountability when our expectation is that money is being spent on residents?
Yeah, I think one of the other laws that advocates are calling for is a direct care ratio, requiring facilities to spend designated portions of their public reimbursement on care. Several states have done it now. And New York was one of them. It passed a law, the budget law, saying facilities have to spend 70% of their revenue on care, including 40% on resident-facing care, all defined in the law, and limiting profits to 5%. And more than 1/3 of the nursing facilities filed a lawsuit against the state, which Richard and I were totally astonished by when we read it. They claimed that if that law had been in effect in 2019, the nursing homes in New York would have had to return $824 million to the state because they did not meet those standards. They were not spending 70% of their revenue on care, and their profits were above 5%. And one of the things I thought was a lot of fun, I enjoyed doing, was looking at those facilities that filed this lawsuit. One of them was a special focus facility candidate, in fact, just sued by the Attorney General 2 weeks ago. This is one of the cases in Centers Healthcare that she has sued the Buffalo facility. This facility said if that New York law had been in effect in 2019, it would have had to return $4.9 million to the state in that 1 year alone, because it didn't spend money on staffing and it had higher profits. So I looked them up on Care Compare, and what did I find? I found a deficiency for immediate jeopardy in staffing. Now, I don't think there are 24 of them in the country a year, but this facility was cited with immediate jeopardy in staffing. And you read the survey report, one of the things that the state found, the surveyors found, was in the dementia unit, in one of the evening shifts, there were 50 some odd residents, more than 50 residents, 1 LPN and 1 CNA. That's immediate jeopardy. It was immediate jeopardy staffing. If there were direct care ratio laws, if facilities were required to spend the money, to me, this is the accountability issue. If they were required to spend the money on care and could not take exorbitant profits, then maybe some of these private equity people would say, well, there's something better we can do. We know they're buying medical practices all over the country. Maybe they'd walk away from nursing homes and say, we don't want to do this because we can make more money elsewhere. But that would require direct care ratio laws that were actually enforced. All these laws are not self-enforcing. Somebody has to enforce them. But that would be another strategy that we would like long range, or soon, not long range. We have 4 or 5 states that have already done it, and Connecticut's on its way. So that's great. Okay, Matt.
Thanks all. How about something a little more on the ground? Lorraine asks, and there's an acronym in here that I hope you guys will know. When one's an independent resident in a CCRC that includes assisted and skilled nursing and wants to report compliance issues of abuse or neglect and doesn't find help, will the state agency really have the capacity to help, or something federal?
If they've got
Yes.
a nursing facility component, the state survey agency is supposed to survey those facilities. But what I've seen is that CCRCs are dropping their nursing home components. They're not going to be having nursing homes anymore. So even though these communities advertise you can get whatever you want whenever you need it, these now called life plan communities, they are deliberately dropping their nursing home parts. But if they have a nursing home part and it'll be surveyed by the state. It should be, and they should take those complaints.
And if they have a home care component, right? So if it's in the assisted living side and they have a home care component, or they have an assisted living service going in, that service should be licensed by public health or those nurses. And so there should be a different type of oversight for that component. So I would say reach out to your ombudsman's office and ask where would be the appropriate place to file a complaint. If they do have a nursing home component and the person's worried about filing an individual complaint, that's when it's important to have a strong resident council and to really work with your resident council or other people seeing the same concerns, getting it in the resident council minutes and using that as an additional tool.
All right, thank you very much for that. Shall we try one of our live questions?
Sure.
Dare we? Kathy C., you are self-muted. If you could click your microphone one time, there you go.
Hi, thank you. This is Kathy Cubitt from CARI. We're an advocacy agency in Pennsylvania. I want to thank you all for your advocacy and work. I just want to mention 2 quick points and 1 question. One is we're also seeing the industry in Pennsylvania use the threat of closing with state legislators in their demands for more money. And they are successful in having many allies for all the arguments that you've already outlined today, but I wanted to throw that one in the mix. We're also starting to see some disturbing trends of long-term residents being discharged as facilities move to wanting to be strictly short-term Medicare facilities. And that's another alarming trend in terms of how they're going about this process. My question is, do you have any recommendations, either state or federally, how we can attract good providers. It just seems like when a facility, even our better providers, want to get out of the business, the only ones that fill that space is the types of providers Richard really described well. And I'm just curious if you have any thoughts on that. And thanks again for everything.
If I can, I really think we need to change the business model. I mean, the business model has been one that you have these predatory operators, and as I mentioned a couple of times, it used to be that there was a significant difference in the not-for-profits. The not-for-profits still tend to do better in terms of staffing and outcomes, but I think we've seen a lowering of a race to the bottom, as I mentioned before. So my point being is that I think if we start pushing this, that there's more accountability for where the money goes, et cetera, it'll be less attractive to these predatory operators, and therefore it'll be a system which we have profits, we have not-for-profit, but they'll be more able to operate in a way that is normalized, for lack of a better way of putting it.
And for us, our for-profit small mom and pops, that's where I would really like to see further expansion. But unfortunately, we see that a compression in that area. You're smaller, somewhere between 30 and 60 beds. When we see those homes where they are owned by individuals who live in the community, who also work in the community, that's when we see the best outcomes. You don't have the large overhead salaries going to a corporation, and just adding beds on so that you can pay for the large overhead salaries. So they may be for profit, but they're a small community-based mom and pop, and they're the people that you have to look in their eyes and Stop and Shop. You run into them, and they give high quality care, and those are our 5-star homes, and those are the homes people really want to get into. However, those are the ones that we don't really see staying in it for the long haul right now.
I wanted to say something about the closures, that nursing homes close all the time. And I've looked into this. Charlene Harrington, I asked her, are there any studies about closures, who closes? And she sent me an article that was maybe 20 years, like 10 years old, and it talked about 20-year-old studies. For years, facilities have been closing, and typically they close because they're poor quality and they have very, very low occupancy. And that's been true now too during the pandemic. Generally, not always, but they have very, very low occupancy and the care is poor. And there have been a number of states that have said we should have a deliberate policy to close these poor quality facilities. If they have a bad record for years and low occupancy, and most people want to stay home, if at all possible, we should close these poor facilities. It's difficult, obviously, for the residents who have to be moved. No question about it, although often they've been complaining about the care. But closures are common, and some of them are the result of deliberate state policy. I think it's the New Jersey auditor who wrote about that, a couple of reports. Like, these are the worst facilities and they shouldn't be in business. Massachusetts committee talked about the same thing. So closures, yeah, they make these the rural facilities are going to close. Meanwhile, North Dakota has one of the highest staffing rates in the country, and that's a lot of rural communities. So the closures are not necessarily just rural. As for the issue about facilities trying to discharge people because they want to be short-term Medicare, I think that's probably something we should have a whole webinar on. I know that's an incredibly important issue, and we have a number of people at the Center for Medicare Advocacy who could talk about that, and maybe that should be a discussion for another day, because it is very serious. There are rights that they have under the Medicare law that are in addition to nursing home reform law, notice and discharge rights, and trying to balance all of those and let people know what they're entitled to and how to exercise their rights is complicated. We have some excellent materials from New York. The Legal Services and Ombudsman program together did phenomenal materials on just these issues. So maybe we could try to put together a webinar on that point, Kathy, and I'd be happy to talk to you about it offline too.
Thanks very much, all. We have so many good questions lined up. I know we're 10 minutes over. We've got 4 hands still up and a queue of questions. I don't know how you guys feel. Maybe one more? Maybe we could
Maybe we
see.
could also, Matthew, the written questions, maybe you could send to us and we can get them back out to people or post them somewhere somehow.
That is a bold thing to volunteer,
Thank
but I can certainly get them to you.
Sure.
Okay,
I feel
Sure.
we should never make a promise that we will answer every question.
We can try.
you could try.
Let's go with one more hand here. I
Okay.
think Andrea has had her hand up for a very long time. Andrea, are you there? Andrea N.
No, I probably put my hand up by accident, but I just want to thank everybody. This is great information, and I did not have it before, and I just want to thank you all for the work you do.
Oh,
you.
well, thank you for that. That was a happy mistake.
That's a nice way. Yeah.
Maybe we should end right there.
Matt, did you say that Mairead had a lot of materials and you were, had them as an additional
Oh,
resource?
Thank you very much, Toby. Yeah, in my patter at the beginning, I forgot to mention that right here in the control panel of GoToWebinar, there's a handouts section, and you can download the slides and some additional resources from the Connecticut Ombudsman program right from that panel. And I did send those out to the email addresses that everybody used to register today. If those didn't make it, probably there was a typo in your email address. But you can grab them right now if you didn't get them in your email.
About resident councils and family councils, really, really important information. Thank you, Mairead.
That's where my dog's going to agree. That's where we find the most strength in buildings, when there's a strong resident council and family council in order to support. So if you have questions, it is just one of the state ombudsmen here put that, or one of the regional ombudsmen put that list together, and we send it out. And if you have questions, feel free to let us know.
No, it's so important having those strong residents and having them be active. I was on a meeting with Connecticut legislators, and one of the residents in Connecticut was talking about how she got one shower a week, and this legislator kept coming back to it. She said, "What did you say? One shower? That's all you get? One? I couldn't live like that." And it went on, and then she came back. She said, "Do you really just get one shower a week?" I mean, it is very powerful when people hear from residents who've become empowered the way, Mairead's program is so excellent. They've really worked with the residents and helped them speak up on their home behalf for those who are able and want to do that. It makes all the difference in the world to the legislators. It's hard to look somebody in the face and say, "Oh yeah, one shower a week, good for you. That's good enough for you." Not for me, but good enough for you. It really is powerful. So those materials are really useful and helpful, I think. Sorry, Matt.
Oh, no, thank you. I think with that, we probably should call things to a close. Any final words from our panel?
you. Thanks
Thank you
very
for
much.
hanging on.
Absolutely. Thank you everybody for joining us this afternoon and staying on a little late. Thank you especially to Richard and Mairead for joining us. Fantastic information. Love working with you guys. Please, everybody who's still on, watch out for registration for our next webinar, which is going to be October 11th, 2 to 3 p.m. Discussion of Medicare enrollment with Associate Directors Kathy Holt and David Lipschitz. Should be very edifying. I want to thank you all again, and I will now end today's presentation.
Thank you. Bye.
Thank you. Bye.
Thank you, guys.
Thank you. Bye-bye.
Bye-bye.